Hello everyone, I'm Joey Thibault from Paris, France. I'm very honored to participate in this Congress, and I thank a lot the organizers for this kind of invitation. My conflicts of interest are on this slide. I would like to start by a few words about physiology, and especially physiology of mean systemic filling pressure venous return. This is a Guyton's model. It's a relationship between venous return and right atrial pressure. When right atrial pressure increases, venous return should decrease, and the intercept of this line with zero venous return is defined as a mean systemic pressure. In fact, it is the upstream pressure for venous return. And according to the Guyton's model, the systemic venous return is proportional to the pressure gradient for venous return and inversely related to the resistance to venous return. And the pressure gradient for venous return is the difference between the mean systemic pressure, which is the upstream pressure, and the right atrial pressure, which is the downstream pressure for venous return. And the mean systemic pressure, which is the virtual pressure considered to lie at the level of the venules, is positively related to stress blood volume and negatively related to vascular compliance. And the stress blood volume, which represents 30–40% of the total blood volume, is hemodynamically active and thus participates in venous return through its impact on mean systemic pressure. And the unstressed blood volume, which represents 60 to 70% of the total blood volume, is hemodynamically inactive and serves as a blood reservoir, then can be mobilized and be converted to stressed blood volume under some critical conditions, such as stress, but also shock states, etc. So the mean systemic pressure is considered a marker of the effective blood volume, but it is very complicated to measure it at the bedside. You can measure it, of course, if there is zero flow, cardiac arrest, but it's not, of course, very convenient in practice. And there are some methods I will speak about later. Cardiac function. The systolic function curve of one ventricle, or the right or the left ventricle. This is also called the Frank-Starling curve. Stroke volume, ventricular preload, and if you increase preload while the ventricle is operating on the steep portion of the curve, you should increase stroke volume, and this condition is called preload responsiveness. But if the ventricle is dilated and operates on the flat part of the Frank-Starling curve, the increase in preload, the same increase, would not increase stroke volume, and this condition is called preload unresponsiveness. But in fact, it also depends on the cardiac contractility. There is a family of curves between a normal heart and a failing heart. And for example, for a given value of preload, this condition could be associated with preload unresponsiveness or responsiveness depending on the cardiac contractility. And also there is a left ventricular and also right ventricular diastolic function curve. This is a relationship between the end-diastolic pressure of the left ventricle and the diastolic volume of the left ventricle. You know this curve, it is also a hyperbolic curve, but in the opposite side. And if you increase end-diastolic volume by giving fluid, for example, if the ventricle is small, normal size, you shouldn't have a big increase in the pressure at the end of the diastole. But if you increase by giving fluid the end-diastolic volume, while the ventricle is already dilated, this increase in volume will increase a lot the pressure inside. And therefore, an increase in preload, for example, by giving fluid, results in a negligible increase in the left ventricular end-diastolic pressure in cases of normal LV size, but results in a large increase in LV-EDP with inherent risk of pulmonary edema in cases of previously dilated left ventricle. In addition, there is a leftward shift of this diastolic function curve in case of reduced compliance of the left ventricle. And therefore, if you give fluid, for example, while the ventricle is small, but with a normal compliance, you should not have a huge increase in the pressure in B, but if there is a reduction of the compliance of the left ventricle, you should have a huge increase in the endoscopic pressure of the left ventricle. And this can happen in clinical conditions, for example, in patients with ischemic cardiomyopathy and other pathological conditions. Now, if the ventricle is operating on the flat part of the Frank-Starling curve, conditions of preload and responsiveness, and if by mistake you give fluid, at the same time, you will increase a lot the left ventricular endoscopic pressure. And this is very important for the clinical practice. You should not give fluid if the ventricle is preload and responsive, because not only this does not increase stroke volume, but also this will increase the left ventricular endoscopic pressure and then the risk of pulmonary edema formation. This is why it is important to identify preload and responsive patients before any fluid administration using dynamic indices of preload responsiveness. And this is not my talk today, but there are many tests now to identify preload responsive patients. Let's go back to this venous return curve. In fact, as you know, venous return and cardiac output are equal at steady state, and therefore we should combine this Frank-Starling curve and this Guyton's venous return curve. And there is an optimal point here, an equilibrium point, optimal for cardiac output and right atrial pressure, which is the operating point. If there is an increased cardiac adrenergic activity, for example, during stress conditions or after administration of beta-1 adrenergic agents like dobutamine, you should have no change in the venous return curve. So this is the same venous return curve, but a change in the Frank-Starling curve. And therefore, there is a movement of the equilibrium point to this here with a higher cardiac output, but also a lower right atrial pressure. And this is beneficial, of course. But if you have a decreased cardiac contractility with no change in the venous return curve, you should have a movement of the equilibrium point to this point now, with a lower cardiac output and a higher right atrial pressure. After these words about physiology, let's go to the effects of fluid on the macrocirculation. And first, fluid infusion should not affect the Starling curve, as it is expected not to change the cardiac systolic function. But fluid infusion should increase the mean systemic pressure. And in this study we performed in my unit with Laurent Guérin, Zelimone, and others, we try to estimate the mean systemic pressure using the end inspiratory and expiratory occlusion methods in mechanically ventilated patients. And it was possible to extrapolate this venous return curve at zero flow and to obtain an estimate of the mean systemic pressure. We did this at baseline before fluid administration and after fluid administration. As you can observe, we had a shift to the right of the venous return curve and an increase in the mean systemic pressure. So this study confirms that what we can expect, that fluid infusion should increase the mean systemic pressure. But we also confirm that it can do this regardless of the presence of preload responsiveness. This is what we found in this study. In both cases, in preload responsiveness conditions and preload unresponsive conditions, we observe an increase in the mean systemic pressure and a shift of the venous return curve to the right. And periodic responsiveness here was defined as an increase in cardiac output after fluid administration by more than 15%. But fluid infusion should increase the venous return pressure gradient only in case of periodic responsiveness. Indeed, if the ventricle is operating on the steep part of the Frank-Starling curve, we should have with fluid a shift of the venous return curve, as I showed before, with an increase in the mean systemic pressure. But because of the steep part of the Frank-Starling curve, we have a movement of the equilibrium point to this now, to this intersection, and now we have a higher cardiac output, of course, but the increase in CVP is lower than the increase in the mean systemic pressure, and therefore the venous return pressure gradient, PMS minus CVP, should increase, and cardiac output also should increase. And this is what we observe in fluid responders, an increase in cardiac output by definition, I would say, but also independently we estimated the mean systemic pressure and CVP, and this gradient increased in these patients. But in case of periodic unresponsiveness, this should be different, because we start from a point, an equilibrium point, which is already on a flat part or almost on the flat part of the Frank-Starling curve. And therefore, if we give fluid, we can move the venous return curve to the right, as I said before, and increase the mean systemic pressure. But due to this flat part of the Frank-Starling curve, there is a movement of the equilibrium point to the right on the same Frank-Starling curve, but as you can see, there is no increase in cardiac output, but a huge increase in CVP, and the change in CVP is more or less the same as the change in the mean systemic pressure, and therefore there is no increase in the venous return pressure gradient, no increase in cardiac output. In this case, we have no benefit in terms of cardiac output, but risk of increase in CVP at too high levels, with some consequences on the kidney function, on the liver function, etc. And this is what we found in this study. We found that in fluid non-responders, we had no change in the venous return pressure gradients, which finally increases only in periodic responsive patients. So fluid infusion should increase cardiac output only in case of periodic responsiveness. And what about the effects of fluids on arterial blood pressure now? In fact, the increase in cardiac output associated with fluid administration should decrease the systemic vascular resistance. And this is well illustrated by this study from the group of Maurizio Cicconi. They gave fluid to patients, and they looked at the systemic vascular resistance before and after administration of fluid, and this subdivided their population in periodic responders and periodic non-responders in function of the increase in cardiac output after fluid administration. As you can see, fluid infusion decreased SVR only when cardiac output increased. This is physiology, and this is due probably to two mechanisms. The first is that when you give fluid, you increase cardiac output in periodic responsive patients, and you can reduce the sympathetic reaction which was induced by low cardiac output, and therefore you can decrease vascular tone due to this effect. Another effect is a flow-dependent vasodilation, which is due to NO secretion in the arterioles, and this is due to the increase in the shear stress on the endothelium of these arterioles, which can result in release of NO in this region, and therefore vasodilation in this region. And therefore, we can expect a decrease in SVR. And what about mean arterial pressure now? Mean arterial pressure depends on cardiac output and depends on SVR. And of course, we could have with the potential increase in MAP only if the increase in cardiac output exceeds the decrease in SVR. So it does not happen in all patients. This is why it is potentially interesting to combine norepinephrine to fluids in shock states with a vasodilatory component. And this is interesting because you can have the advantages of the combination of fluid plus norepinephrine, which are first to increase the mean systemic pressure more than fluid alone, resulting in the better cardiac output. This is what we investigated in this recent study with Imenada, Zebimone, and others in my unit. We performed passive leg raising, PLR, to replace fluid administration, and we estimated the mean systemic pressure as we did before, using the inspiratory and expiratory occlusion maneuvers. And we looked at the changes in mean systemic pressure, which always, with a high dose, of norepinephrine, which is here higher than the change in mean systemic pressure with a low dose of norepinephrine during PLR. And therefore, we conclude that norepinephrine is able to potentiate the efficacy of volume expansion on mean systemic pressure, because in all cases, PLR increased mean systemic pressure, but more with a high dose of norepinephrine compared to the low dose of norepinephrine. So there is a synergistic effect of the combination. Another advantage, of course, is to correct hypotension better than fluid alone, because norepinephrine could not decrease SVR as fluid is able to do because of the alpha-1 properties of norepinephrine with vasoconstrictive effects. And also, the combination is able to limit fluid overload. This is a retrospective analysis of a large cohort of patients with septic shock. And we did this with Gustavo Ospina-Tascon, Daniel De Backer, Jan Backer, Glenn Hernandez, and others. And as you can observe, we looked at the resuscitation of fluids in terms of volume and time in patients who receive norepinephrine very early, within the first hour after starting fluid administration, and patients who receive norepinephrine after 1 hour, after the first hour following fluid administration. So this is a delayed administration of norepinephrine. As you can see, less fluids are given when norepinephrine is administered early. So my conclusion, fluid infusion is able to increase the mean systemic pressure. This is why it increases venous return and cardiac output in prolonged responsive patients, but this also leads to a decrease in SVR. Therefore, there is a potential increase in MAP only if the increase in cardiac output exceeds the decrease in SVR. This is why it is potentially interesting to combine norepinephrine to fluid in shock states, at least in shock states with a vasodilatory component. Thank you very much for your attention.